Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about the uteroplacental insufficiency. Okay, so meaning thereby that the uterus is being supplied by the uterine arteries both from the right and the left hand side, and then we identify that as the demand increases, the supply increases. I do have a lot of videos regarding this uteroplacental insufficiencies earlier also, and starting from 12 weeks to 16, 18 weeks to something around 26, 28 weeks, we do have an established nomograms regarding the blood flow in the uterine arteries. Okay, so that we can quantify by doing the RI or the PI, which is called as a resistance index or the pulsatility index. So we do have very well established nomograms, so we can plot all those values of the uterine arteries onto the graph, and then we can identify how much amount is the blood flow, whether it is flowing less and all those stuff, you know. And similarly, we can have the similar nomograms for the umbilical artery, which is the conduit from the placenta to the fetus. So, meaning thereby that actually the umbilical artery supplies or takes away all the nutrition through the placenta and supplies it to the fetus, and which is very, very important and pertinent as far as the growth of the baby is concerned. So, now we are talking about two different conditions, but almost the same clinical profile. So that would help us understanding, and probably I'll try to explain that. Probably we'll try to pick them up early as possible, so as to avoid some sort of a very severe growth restrictions happening at 29 weeks. Okay, so this is the case one. You try to look around in here, and therefore we are having this RI and PI on the right and the left uterine arteries. We plot onto a graph, and then we identify that the RI is greater than 95th centile. Similarly, the PI is also greater than 95th centile. So, meaning thereby that we are having a very precarious blood supply in the uterine arteries. The second case that we are seeing at 29 weeks, right, and then the umbilical artery flows are very mere, and I'll explain all these things in a greater detail. And then we are identifying that the baby is a very difficult situation. This is the different vessels. So this is ductus venosus. The earlier was a preload index IVC, which is normal at the moment. But how this is how it manifests. Now you see we are having only four cotyledons. Okay, so this is the very small calcified, very very small placenta, and therefore it doesn't have that much of capacity to suck up all the nutrition and supply to the baby, right? And therefore it has not grown that big, right? And then we are having this dropout areas, which is called as a fibrinoid necrosis. And then if we look around in a greater detail, we can identify that the baby is not in a cardiac failure at the moment, right? But if we do the biometry, we identify that the baby is hardly growing. So the baby has got a very severe IUGR, and we can identify by this graph. So uterine arteries can be looked around at 12 weeks. If they are being missed, they can be definitely looked around at 18 weeks when we are doing the anomaly scan. And then we can plot onto the graph so as to identify both the RI and the PI, which is called as the resistance index or the pulsatility index. We do a very well established nomograms for both of them. If they are greater than 95th centile, then probably we do absolutely we would need to intervene in between, and to probably we need to shore up the circulation and supply to the baby by doing low molecular heparin or by doing ecosprints. If we sort of don't give any heed, and probably we miss out on this opportunity, what happens is that at 20, 29 weeks, we can end up with a preeclampsia or a PIH, which is called as a pregnancy-induced hypertension. If she if the mother loses some protein into the urine, it is called as a preeclampsia. So, meaning thereby that in that condition, the pregnant, we probably need to salvage the pregnancy or the mother. So the mother is leading up with a very high blood pressures, so probably we need to decide upon how do you look around, whether you look around for the mother or do you look around for the fetus. Now the fetus is 890 grams, right? And then you don't have that much of window of putting her up on steroids or magnesium sulfates or low molecular heparin. In the meantime, her conditions is deteriorating, right? So the in the second case, we've identified that the umbilical artery resistance was very high. Any resistance in the umbilical artery grade SD greater than 4 is as good as an absent endospheric flow. And then we've identified that the placenta has shrunk, and therefore we have had only four cotyledons, and therefore the base of the placenta has also shrunk, and therefore the net through which the placenta is able to suck up all the or suck up all the nutrition and supply to the baby has really shrunk, and therefore we really cannot Meaning that the potential of the placenta to supply to the baby is very, very precarious, right? So in that condition, now it becomes very difficult for a matter of days. As a matter of fact, we forgot about the weeks. Now what we are dealing up with the situation is at 29 weeks now, and then the baby is showing a growth lag of something around 2.5 weeks or 2 weeks, and therefore the baby is something around 893 grams. So that is what it is. Okay, so just to avoid these sort of an difficult situations happening at 29 weeks, and therefore landing up with no man's land, it is always better to see the uterine Dopplers at 12 weeks or more so at 16 weeks. If they are being missed, then we can do it at 20 weeks, and therefore we can plot onto a graph, and therefore we can give some sort of an support so as to increase the blood flow in the uterine arteries, either by doing the equaspirin or low molecular weight heparin, so that we can take the pregnancy to 34 weeks at something around 1.8 or 2 kgs of the fetal weight, and therefore it is a take home baby, right? Okay, so meaning thereby that probably from 894 grams or something 900 grams, we are able to increase the weight to something around 1.8, 1.9 or 2 kgs, and therefore both the mother as well as the baby's life is being salvaged, right? So this is very, very important and pertinent so as to see for the uterine artery Dopplers as well as the umbilical artery Dopplers at the very appropriate times, and therefore not to panic and not to see absolutely at 29 weeks, because it hardly makes a difference by that, right? Thank you very much for your patience.